Welcome to our presentation on pituitary drugs, led by Professor Yasin Tayem, MD, PhD. Today, we will explore the critical role of these medications in managing pituitary disorders. Hypopituitarism involves deficiencies in pituitary hormones like ACTA, TSH, LH/H, GH, and ADH, leading to conditions such as secondary adrenal insufficiency, hypothyroidism, hypogonadism, growth hormone deficiency, and diabetes insipidus. Treatment of hypopituitarism typically involves replacing the deficient hormone. In most cases, we focus on replacing the target gland hormone such as T4, rather than the pituitary or hypothalamic hormone. In cases of cortisol deficiency due to CRA or ACTA insufficiency, the most urgent treatment is hydrocortisone administration to address potential shock. For TSH deficiency, treatment involves replacing the target hormone T4 using levothyroxine to manage secondary hypothyroidism effectively. LH/H deficiency treatment may involve direct replacement of sex hormones or using LH/HA or GnRA, depending on gender and fertility desires. In adult men with hypogonadism, treatment varies based on fertility interest. For those interested, GnRA or FHA/LH replacement is used. Otherwise, testosterone is administered to enhance sexual drive. For adult women with hypogonadism, FHA/LH replacement induces ovulation if fertility is desired. Otherwise, estrogen with or without progesterone is used to prevent menopause. Growth hormone deficiency in children is primarily treated with recombinant Regia, such as somatropin. Monitoring height and AGF1 levels is crucial for effective management. Adverse effects of Regia, like somatropin, include hyperglycemia, pancreatitis, gynecomastia, nevus growth, edema, and scoliosis, necessitating careful monitoring. ADH deficiency or diabetes insipidus results in polyuria, nocturia, and polydipsia due to the posterior pituitary's inability to regulate water balance. Desmopressin is the preferred ADH analog for treating ADH deficiency, as it avoids vasoconstriction. Vasopressin is a second-line option due to its vasoconstrictive effects. Hyperpituitarism involves excess pituitary hormones, such as prolactin and GH, leading to conditions like hyperprolactinemia and growth hormone excess, causing gigantism or acromegaly. Dopamine naturally inhibits prolactin. In hyperprolactinemia, decreased dopamine leads to increased prolactin, causing symptoms like galactorrhea and infertility. Cabergoline, a dopamine agonist, is the drug of choice for treating prolactinomas, effectively reducing prolactin levels in both macro and microadenomas. Ergot alkaloids used in treating prolactinomas can cause adverse effects such as finger vasospasm, pulmonary infiltrate, hallucinations, and gastrointestinal upset. GH adenomas result in gigantism in children and acromegaly in adults due to excessive growth hormone production, requiring targeted treatment strategies. For acromegaly, surgical removal of the adenoma is preferred. If surgery is not feasible, medical treatments like octreotide, cabergoline, or pegvisomant are considered. Somatostatin, a natural GH inhibitor, is used in the form of octreotide to manage GH excess. Cabergoline and pegvisomant are additional therapeutic options. Octreotide, used for GH inhibition, may cause adverse effects such as hyperglycemia, gastrointestinal distress, and B12 deficiency, requiring careful patient monitoring.